Ladies and gentlemen, welcome. You're attending the 152nd meeting of TACIR, and we appreciate you being here. We appreciate all that is done here. We certainly appreciate our staff and the great work that they do. In order to deal with something that some of you might be here on and save you some time, if there is no objection, subject to the approval, where's the tab 7, the Senate Joint Resolution 593, Multi-School Systems for Counties. Today we had the final report up for approval. I've had several municipal mayors call me over the last couple of days, one at about 10 minutes till 10 last night, and there still is not comfort in this. There is no deadline, so if there is no objection, I would like to have two things. Number one, permission to move it to our next meeting. And if we do that, then I would like to have permission to get 4 or 5 county mayors and 4 or 5 city mayors and sit down like we did the internet sales tax, off the record without the cameras, and just knock it out and find out what the problems are and get this finally resolved. To our staff who has bent over backward to meet every phone call, thank you. To TML, who has bent over backward and spent hours and hours and hours on this representing their mayors, thank you. For the county services, I don't see David. Oh, I'm sorry, Dave, didn't see you back there. He's even met with me on this, and they've knocked themselves out. So let's make sure that we get this done right, that we don't favor anyone, that we only do what is right. So if there is no objection, can we have permission to move it to the next date? You need a motion? I guess. Why not?
So moved.
Any objection? Okay, without objection, it's moved to the next meeting. Now, there is no deadline. We're not fighting a deadline. I hate to do that, but this is too critical. We need to get it right. And secondly, would it be permissible if we need a motion, can we get a motion to let, would you mind to do that for us, Mayor Greer, to get 3 or 4 county mayors involved? Maybe we need some large mayors and some small counties. And Mayor McDonald, would you mind to get some city mayors together? And let's meet somewhere and close the door and have the staff there and just go through this line by line, so that if everyone leaves mad and no one likes it, then I assume we've done a pretty good job. If we need a motion, I don't know that we do. Okay. Then let's be advised that we're going to do that unless someone objects. All right? Okay. Thank you so much. Today we start with something near and dear to my heart. Extremely interesting. My wife is very much a proponent of the matters that Chairman Smith has brought to our attention. Oh, wait a minute. We need to do the minutes. I'm sorry. I got all excited. So,
Mr. Chairman.
Yeah. Yes, sir.
Are the minutes dear to your heart?
No, they're not near. My wife doesn't care about the minutes. She cares about this right to shop. And so I was afraid she was watching. I wanted to make sure that she got first billing. All right, have we reviewed the minutes? Do we have a motion to approve the December 2019? We have a motion. Do we have a second? We have a second. Are there any objections, comments, any corrections, additions, modifications of the minutes that are necessary? If not, we have a motion and a second. All in favor of approving the minutes as presented, say aye. 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 Any opposed? No opposed. All right. Dr. Lippert, will you give us your comments and update us on these issues that we need?
We have a short commission and staff update before we get to Chairman Smith. First of all, last month we told you about how Chairman Carter had requested an AG's opinion on the subject of fiscal capacity and our role in making changes to fiscal capacity. The specific question was whose approval is required for changing the data sources in the Tennessee Advisory Commission on Intergovernmental Relations fiscal capacity model used to equalize funding through the basic education program funding formula. They responded last Friday, and the official response is changes to the data sources in the Tennessee Advisory Commission on Intergovernmental Relations fiscal capacity model must be adopted by the State Board of Education and approved by the Commissioners of Education and Finance Administration. Legislative approval is not required for such changes, nor is approval of the BEP Review Committee, which is consistent with what we thought our authority was on the matter. So we were very comfortable with this AG opinion. And then we have a quick staff update, unless there's a question on that. Okay. Staff update. Michael Timmy, are you still here, Michael? Stand up, Michael. I know it doesn't look like it could be possible, but Michael Timmy is celebrating 30 years of employment with the state of Tennessee, and we recognize with him that today. Of course, Michael's our Director of Administration. He's the one to make sure that, well, all that stuff happens that has to happen. So thanks, Michael. Mr. Chairman.
All right, are we ready to get started? All right, under tab 3 is Public Chapter 407 Acts of 2019. We've entitled that the Right to Shop Bill. Chairman Smith has brought that bill. One of the things that I like most about the legislature, and particularly TACIR, is to know what the problem is and what we're trying to cure, what we're trying to change. So with permission, could we, Chairman Smith, do you mind to give us a few minutes, just a quick comment on what you're seeking to do here and what this is all about, and therefore explain the role that we're going to play in this? And then Jennifer will be to you right after that. Thank you.
Thank you, Mr. Chairman, and thank you, distinguished panel. Your work is extremely important to our state, and I think Tennessee has a unique way of doing things, and that's through collaboration. So accept my congratulations in advance for the good work that you've done. One of the things that I would also be mindful to note is that when we think about health care, in talking with Chairman Carter and Dr. Lippert, apparently this committee has not heard a health care bill since, I want to say, 1994. It's been 25 years since a matter of health has come before this committee. But I would dare say that in your budget items, whether you're at a city, county, or a state level, health care is one of your big cost drivers in your budgets. And so what we're trying to do with the Right to Shop Act or bill, which is law in the state of Tennessee, is to present consumerism back into the area of health care, meaning that patients would be empowered to shop, have information in advance. And if I could, Mr. Chairman, take a little bit of a everyday example. As you drove here, you were afforded the opportunity to look through your windshield to navigate where you were going, and you use your rear view mirror to see where you have been. What we're witnessing in our healthcare markets writ large, not just in the state of Tennessee, every transaction of healthcare is viewed only through the rear view mirror, and you're only able to see the cost of things after that action has been delivered, that service has been provided. And what we're trying to do in the healthcare market in the state of Tennessee is to reconstruct that so that consumers have a windshield approach. We are afforded that in the area of property insurance. We're afforded that opportunity in the area of life insurance and in auto insurance. We're not afforded that in the area of health care insurance. When you think about when you change your oil, when you add a new roof to your house, all of those things, you're able to see those prices in advance. So while some may argue that, oh gracious, this is a mandate, actually we are reconstructing the whole contortion and deconstructing all of the problems and trying to empower those who pay and those who consume in the healthcare space. So what this bill does specifically is it was a first primer introduction into consumerism, where we identified 4 shoppable services in advance, working with the insurance industry: laboratory services, infusion services, occupational and physical therapy, as well as radiology, imaging services, that in the day of premiums going up, in the day of deductibles going up, in the day that co-insurances are going up, more and more health care is paid out of pocket. What does that mean? That means that Robin Smith, sitting here as a state representative, did not meet her deductible in 2019. It means that out of my paycheck came the premium cost. And then when I did go to my checkups, everything was paid essentially at a cash level because I had not yet met my deductible. I had the contracting leverage, but I was still paying cash. It's important that we be able to consume and shop. I could have shopped if I needed an MRI, gone on to the Blue Cross Blue Shield, United Healthcare, Cigna portals. Today, Cigna, United Healthcare, and Blue Cross Blue Shield all already have shoppable portals for their members. This was just a piece of law that codified that request and asked and put into law an incentive program. This is nothing that has not been done in other states. You'll hear momentarily from someone, from the commissioner from Kentucky, the Commonwealth of Kentucky, and how that they have saved millions of dollars using this in the state space. So I'll be happy to answer any questions that you might. But in the day of budget pressures, whether at the state, whether at the county, city level, this is just an introduction through law of reconstructing and returning to the healthcare market a free market approach that empowers consumers, empowers patients, and allows us to see a prospective look at spending and not a retrospective look at just the billing. And I would offer one last comment, Mr. Chairman, if I might. I was recently able to sit down with constituents in Chattanooga, and I asked them to take a piece of paper and write their definition of insurance, because they sold health, life, different products. And we all had different ideas, and I had submitted this to them. Insurance is a financial product where premiums are paid to aggregate shared risk for the purpose of buying power and pooling risk to prevent financial ruin. That applies in auto, property, casualty, and life. That does not apply in healthcare. In healthcare, insurance is a transactional monitoring service that dictates pathways of care and limits consumer choice based on contracts. What we're doing in Tennessee is reconstructing again the market to make it windshield, not rearview mirror, and we're returning to the true definition of insurance. We need insurance. Don't hear me any other way. We need insurance. We just need insurance to be affordable, based on value, and empowering our patients. Mr. Chairman, at this time, I'll be happy to take questions.
All right, thanks so much, Chairman Smith. Questions? All right, thank you. That's very helpful for us to understand that. And so now, Representative Parkinson, I just now saw his.
You don't have to sit back down, Chairman Smith. I just want to tell you thank you. Thank you.
All right, anyone else? All right. Jennifer, you ready to go? Jennifer Berry, our Senior Research Associate, is on this, and so she'll present the panel and give us the overview. Jennifer?
Thank you, Mr. Chairman, members of the Commission, and Chairman Smith for being here and giving that introduction. My name is Jennifer Berry. I will be introducing the panelists, but before I do that, I wanted to give you a brief overview of the study, and I'll probably reiterate a couple of things that Chairman Smith mentioned. And the memo is behind tab 3. Public Chapter 407, Acts of 2019, directs the Commission to study any cost savings realized by enrollees with health insurance plans in states that have adopted legislation or programs that require insurance carriers offering health plans in those states to offer incentive programs to enrollees for shopping for healthcare services at lower costs. The legislation requires the study to include, at a minimum, an examination of savings realized by these types of programs in Maine, New Hampshire, Florida, Arizona, and Kentucky. The draft report will be presented at the summer meeting and the final report at the fall meeting, and the report is due to the General Assembly by the end of 2020. The Act requires insurers to provide information that enables the insured to shop around for the best price on medical services and authorizes insurers to offer incentive programs to reward the insured for choosing lower-cost services. These incentive reward programs are commonly called right-to-shop programs. Their intent is to address rising healthcare costs by encouraging the insured to switch to lower-cost service providers. In these types of programs, if the insured chooses to receive services from a provider at a price that is less than the average price for a service, then that person usually will receive a check from the insurer that is a percentage of the saved cost, and usually from $25 to $500. Tennessee's law limits the amount a person can receive per year to $599. With that brief overview, now you will hear from three experts who represent different perspectives on the issue. I will introduce them, then each person will speak for 5 minutes. After the panelists have all presented, we'll have plenty of time for questions and discussion. So I ask that you please save your questions until after all three panelists have had a chance to give their opening remarks. And two of the panelists will use PowerPoint slides, which are in your docket books behind tab 3. So first we'll hear from Josh Archambault, Senior Fellow with the Foundation for Government Accountability. Then Ms. Jenny Goins, Commissioner of the Department of Employee Insurance in the Kentucky Personnel Cabinet. And finally, Nathan Ridley, attorney with Bradley, Arrett, Bolt, Cummings. And now I invite the panelists to come up to the table here, and Ms. Goins and Mr. Ridley can sit near the laptop, and we'll have Mr. Archambault start us off. Thank you.
Ladies and gentlemen, thank you so much for being here. I'm sorry we have on the list for? Okay, all right. Is that for this meeting or the one to come in May? Okay. Ladies and gentlemen, pleasure to have you here today. Thank you for your time and attention to this. Who wants to go first? Ladies first, or have you organized it in a way that's, all right.
I think I'm the first victim, Mr.
All
Chairman.
right.
Yeah.
Mr. Archambault?
Yeah, Mr.
Thank
Chair-
you for being here.
Well, thank you for having me. Thank you, members. My name is Josh Archambault. I'm a senior fellow at FGA. We're a national think tank that works in 30 states and in D.C., researching and sharing ideas. I wanted to start with a short story. Paula Bennett is in her early 50s and suffers from Crohn's disease. Her infusion treatments at a facility cost $40,000 per treatment, which happen every 8 weeks. And she pays a $30 copay every visit. Even with generous insurance, the costs add up, and the huge price tag push premiums higher. Under a program very similar to what's contemplated in the bill passed here in Tennessee, Paula was informed of a provider that charged 90% less, was still in network, and in return she got paid $500 per visit instead of paying a copay. Same drug, same delivery, same frequency, but higher quality care, one-on-one care, but for much less. That's what's possible when she was granted the right to shop. Now, sadly, wild price differences are not that uncommon, maybe not 90% all the time, but huge nonetheless. It's similar to a car being listed for $15,000 at one dealer and over $100,000 down the street for the exact same car. Locally, Healthcare Blue Book has documented these price differences exist all over the state of Tennessee. Now, when Tennessee families overpay for healthcare, they have less money for groceries, education, or some of them can end up in medical bankruptcy. Now, price transparency sounds great on paper, but does it actually work? The short answer is yes, but it does require some basic education and time to change behavior. But real price transparency can deliver something that's almost unheard of in healthcare, positive cost savings trends. For example, in New Hampshire, a program for public employees, for those who are using the price transparency tool, 75% of them are shopping every single year. Average savings when an incentive or shared savings payment is made is over $500. This is translated into about roughly $400 of savings per member every year, even for those that aren't using the program. Perhaps most encouraging is that patients and providers have started to internalize the change, as the amount of shopping resulting in the incentives has increased 600% since the first year. When done right, patients win, high-value providers win, and those paying the bills win. Now, I should mention many large self-insured companies have had price transparency for years and have added similar incentive-based programs to invest in their employees' health and save money in the process. In our research, we have found a few key factors that are needed to be most effective to change behavior. So first, let's talk about prices. Ideally, the prices are what was actually paid, real prices, for all or most services. And that information is provided to patients even when they've exceeded their out-of-pocket responsibility. So they've exceeded their deductible. Now, average prices are helpful as an anchor, but more information is better for patients when it's presented in a consumer-friendly manner. Second, incentives increase engagement. When real price transparency is paired with the shared savings incentive, it really is a powerful carrot over the medium to long term to change patient and provider behavior. It takes time. Third, education is essential. A commitment to basic education by an employer or an insurer is important. That includes before an interaction and also after, when a patient has overpaid. And then finally, we've noticed that in a handful of states that have passed a consumer protection allowing access to out-of-network lower-cost providers. It's another more powerful market-based incentive. 12 states have or are in the process of launching right-to-shop-like transparency and shared savings programs. They all look a little bit different, but many are starting with their public employees. My point is, these programs are not administratively costly or overly complex, as there are a number of vendors on the market who already have affordable products, and most have achieved positive return on investments in year one. Now, of course, I want to acknowledge that experience, and probably if you talk to your own family members, not everybody's going to shop for healthcare. But even those that don't shop appear to have reap an indirect benefit, with newer lower cost providers entering the market, or a non-shopper showing up to a provider who has adjusted their prices. Some good research from the University of Michigan just was released a few months ago highlighting this fact. Now, when comparing the Tennessee law to other states, the one here is more limited. I noticed at least 5 major differences I'd be happy to discuss in our conversation. I did want to mention that FGA has no financial relationship with any transparency company, insurer, or any other company in this space, but we do ask lots of questions about what works and what doesn't on price transparency. In closing, I did want to note a couple recent federal actions on price transparency. New rules for hospitals and insurers will require disclosure that is far more robust than what's contemplated in this new law. The new federal rules are, I don't believe, in conflict with the Tennessee law, but I would argue build on the concept and will require much more robust disclosure. In addition, the insurer rules contemplate shared savings incentive programs, which we believe are a good win for both consumers and insurers. Thank you for having me, and I look forward to our discussion.
All right. Thank you so much. Ms. Goins, are you scheduled next? Thank you for being here. Welcome.
Okay, what I want to do real quickly is share our success.
I'm not sure your mic is on. There's a little button down there. It looks like someone's speaking.
Now it
a
looks
little
like
red.
it's on, sorry.
Yes, ma'am. Thank you.
I thought red meant stop. It wasn't on. So what I want to do is share our success with the Kentucky Employees Health Plan. So I'm the commissioner for the plan. I've been with the plan since 2008. I became commissioner in 2016. So I've had a lot of experience with our plan. Who we are, just real quickly, we are the health plan for all the public employees across Kentucky. In fact, we're the largest self-insured health plan in Kentucky. We cover 6.6% of the state's population on our health plan. Most of our population are our educators and folks who work in the school boards. Our early retirees are those folks who retire, and before they reach 65, they stay on our plan. When they go reach age 65, then they go on to the Medicaid plan, or Medicare plan, with their retirement system. State agencies are one of the smaller groups with about 19%, and then we have quasi-groups who make up the rest of our plan, and those are our local city and county agencies, local libraries, fire departments, sheriff's office, etc. We've been self-insured since 2006. We are now up to a $1.9 billion health plan on our annual spend. So I said how large we are with the, how many people we cover across the state in a percentage, but the employees and retirees come into about 186,000 plus members, and when you add on their families, we end up covering almost 300,000 covered lives. So we're a very big plan. That means we cost the state of Kentucky a lot of money. So this is our biennium budget. We're in our legislative session also. And so it is very imperative as a self-insured plan that we constantly look for ways that we can save money. And part of that relates to being able to have transparency and teach our employees and their families the cost of health care, because so many of us growing up or going to the doctor, and no offense to any doctors in the room, but at one point the doctor was God. If the doctor told you to go get some kind of service, you went and got that service and you did not ask any questions. Doctors need to have conversations, and people need to have conversations with their doctors. I'm very fortunate to have a fantastic primary care physician in my local area, and he's very good at that. Some doctors are not, and so they need people to help coach them. And we as a health plan have the responsibility to help educate people on how to do that. And the transparency program is a way to do that. In 2013, transparency was introduced to our Kentucky Group Health Insured board members. And honestly, one of the board members stood up afterwards when we were talking about how you compare prices, how we would incentivize members, and how that could save us money, and said literally, this is a no-brainer, we need to try this. So we did a pilot for a year. It was extremely successful, and I'll share some data with you because data is very important to me, and I'm sure to you as you're studying this. We tied transparency into our consumer-driven health plans, very similar to a high-deductible plan. We don't call them a high-deductible plan because they don't meet the federal requirements of a high-deductible plan. For our public employees, these are important plans because they have higher deductibles than a PPO, but they're not as high as a true high-deductible plan, and that's important for public employees, I think. So in 2014, when we introduced transparency and also consumerism, we had about 43% of our population move away from the traditional PPO with a copay into these consumer-driven health plans, and we now have up to more than 60% of our population. And I can see the tie and I didn't have time to kind of do the full map, but to really look at over the years how consumerism has grown with the consumer-driven health plans, but also has our increase in transparency in shopping. So the way it works for us, we are self-insured. So we use outside vendors. We have a third-party administrator, we have a pharmacy benefit manager, and we have a transparency manager also. And we happen to use Smart Shopper. I'm not here to sell any one program. I'm here to tell you that this works, and everyone should be doing it across the country. So basically, your doctor recommends a medical service. You go online or you call and you find out about this medical service. You know, I have so many stories from people. I use mammogram, for example. Many women need to get those at a certain age annually. It's covered at 100% if it's preventive. But you go get that mammogram and you're going to be incentivized. Just recently, I had a woman come tell me that she was in the same parking lot as the original provider the original provider that she was referred to, went to the provider in the building next door, saved the health plan money, and she was incentivized. So it's extremely simple. You go to the location of your choice, but if you choose a lower cost facility in our program, then you are incentivized. There are many different options or programs that we've chosen to incentivize, and I'll explain how we do the incentivization. But when we're looking at the different options, whether it's an ultrascan, mammogram, colonoscopy is one of our biggest shopped items, and it also saves us a lot of money. But you need to look at the time it takes to shop. You need some time. I mean, not time it takes, but you need time. It needs to be something elective. It's not going to work for an emergency type procedure. You need enough providers to give options. So there needs to be, in the network, you need to know what the costs are, and providers, there needs to be more than one or two providers in an area. And then the cost variation, and the cost variation is important. I can tell you we just had, it turned out to be the same board member, had a hospital in his local area contact him because he was frustrated because he did not show up on the shopping for the different procedures in his area, and he has those procedures in his hospital. He didn't show up because he's not a lower cost provider. He negotiated with our third-party administrator. He is now a lower cost provider and showing up on that recommended provider to go to be incentivized. One way it works, another way that it works. Here's some examples of the incentives that you can earn. And the way that we're looking at the incentives when we work with our particular vendor, you can see back surgery. That's a very expensive reward amount. If you go to the lowest cost provider, $500, $250 if you go to the second lowest. The way that we're working and coming up with these incentivized numbers, because I know you have some similar information in your bill, is we look at the number of providers in that particular zip code area. We also look at the cost, and then what we do is we target 15 to 20% of that cost differential to share with our members. None of the costs, there are a couple that hit all the way up to the 30% mark, but that's the greatest incentive that we provide is the 30% when we look at the cost in our particular area. Engagement in a public employee health plan and in many health plans, if you think about yourselves, how many of you are truly engaged with all the benefits that your insurance company offers? There are probably one or two that you're very engaged with. So engagement, when we cover 6.6% of the population, can be challenging. What we did was a couple of years after we had started the program, we knew we really needed to increase engagement. If we're going to save money, we saved it from the beginning, but we wanted to save more. I guess as commissioner, I'm a little greedy. I look at those dollars all the time because we're spending state money and employee money. So we offered a $15 incentive. 1,000, that was to go to 1,000 new registrants, new households. We had this whole communication plan built out for a month. We went through those $1,000 $15 incentives to activate your account within a day and a half. But it made a big difference. And so what I have below are the results. When you look at the activation, we started getting more people activated. People started shopping. On this next page, what I want to show you are real members from different areas within our state. Right after they registered through this event, they actually started shopping and saving money. I'm not going to read the whole thing to you because I only have 5 minutes. You have it in your packet, but it worked. The key numbers that I want to share with you, we have saved since 2013 when we did our pilot with just the state employee group. So that was the smaller group of about 30,000 employees, $12.6 million. Now that's actual claim savings. That's after we've already given the incentives to our members. We've given members $2.3 million. The average savings per shopped activity is $554. The activation rate is not as high as I'd like to see it, 13.48%, meaning people who are registered and actually activating their account by calling in, whether they shopped or not. We've paid out almost 23,000 incentives, almost 900,000 shopping activities. But I can tell you, as someone who's responsible for the budget of the Kentucky Employees Health Plan, being able to say to our legislators that we're saving $2 million a year just for our health plan with this shopping activity is extremely important. Real quickly, a program that we started this January that I don't have any data to share with you is we're taking that same program of let's look at lower cost facilities and we're adding in quality measures. So like many plans, we have trouble with musculoskeletal issues, lots of money spent on hip, knee, and back surgery. We're focusing on 2 procedures, hips and knees. And so what we've done is we've worked with our vendor and we're looking at not only the cost of that program, we're looking at the quality measures. So we're using the 5-star program from Medicare, Quantros, quality measures, and we're finding out what that sweet spot is so that if you're getting hip surgery, you want to go to that high-quality provider. But we also want you to go to that provider that is also lower cost but high quality. And so this is a new program that we're implementing in January and we're very excited about. I have a few more slides that go into details, but I'm going to stop now. I'm at my 5 minutes, I think. So I'm going to turn it over to the next speaker.
All right, thank you very much, Ms. Goins. Nathan? Oh, there you are. Yes, sir. Mr. Ridley, you ready to go?
Representative Smith told me to leave.
I think that's me. Now, how do you go to the next slide? Okay, perfect. Okay.
Ready?
Yes, sir.
Thank you for being here.
Thank you, sir. Good afternoon, Mr. Chairman and members of the commission. It's a pleasure to be with you here today. I'm Nathan Ridley. I work for the Nashville office of Bradley Arent Bolt Cummings here in Nashville. I'm pleased to be here today on behalf of America's health insurance plans. And let's see if we can do it this way. Yeah, there we go. There's the thank you slide. You try to teach your children to have an attitude of gratitude, so I have those in every one of my presentations. Sometimes I know we have time restrictions today, but sometimes we learn more from your questions than just me rattling on. So if you have something, I'll try to volley forth, and we can do that at the end as well. AHIP, or America's Health Insurance Plan, AHIP's the acronym. They're a trade association of plans. You might not be of health insurance providers. You might not be familiar with the name of them, but you're familiar with the names of their members. For example, Anthem, Blue Cross Blue Shield, Cigna, Humana, even Aflac here in Tennessee. And you'll also know that the CEO at Blue Cross Blue Shield and our former TennCare director, J.D. Hickey, is a board member for AHIP. And then our mission, it's sort of interesting towards the end, I think Representative Smith and I are trying to get to the same place because we try to advance affordability, value, access, and well-being of our members as well. And then here's just a quick slide that Senator Alexander used in some of his presentations last year when he was working on the surprise billing issue, and he was trying to coach his members of that Senate committee up that there are segments of the health insurance business. And you see each line of those is a different segment of the business, and some of those are subject to state regulation and some of them are not. Because if a plan is self-insured, the federal statute prohibits states from affecting those plans, and you'll hear the acronym ERISA sometimes. And by statute, under this bill, part of the negotiation was 1.4 million Tennesseans will not be affected by this because they're in the TennCare program. And we also won't affect 700,000 Tennesseans because they don't have any insurance, just the way our bill's structured. So I got tickled when the commissioner used her word cloud. I find these irresistible, so I used one too. The healthcare system, as Representative Smith noted as well, it's complex, it's specialized, it's expensive, and it's big. It's about $3 trillion across the country, and that's about 18% of our gross domestic product. Ms. Berry's already told you the statute that we got. This was just a backstory to help some of the members, our legislative friends will know this, but this was part of a House Republican Caucus initiative. The acronym was CARES, and that stands for Consumerism, Access, Rural, and Empowering. So that was sort of the tagline for this statute. And then the sponsors, of course, were State Representative Robin Smith from Hickson, Tennessee, in the southeast corner, and then State Senator Kerry Roberts from Springfield, Tennessee, in Robertson County. Ms. Berry, again, mentioned your study states. You have Arizona, you have Florida, you have Maine, you have New Hampshire. I'm leaving one out. That might be Kentucky. Of course, was one to look at as well. And we don't have time to go through all those states. They're all a little different, but there's some common themes between the states. Just as we have Commissioner Goins here today, some states have concentrated, not by statute, but just by policy decision, because she's a good budget person, on their state employee health plan. And then some of the statutes refer to the commercial market as well. So we'll skip over these really quickly. And with all pieces of legislation, there are a host of little bundles of compromises that go into structuring a bill such as this one. And the biggest concern of the insurance industry, as we started on this conversation with the introduction of House Bill 419, was whether or not the provider had to be in the network. Because we weren't ever going to get comfortable if the right to shop or the right to seek the incentives was from an out-of-network provider, because as a plan, we negotiate hard with our providers to test their credentials and to set their volume discounts. I mean, part of being in the trade-off for the healthcare provider to be in a health insurance network is that for this rate, I get this number of people. So it's a trade-off of volume for price, and that's the power of the network. And another part of the network is we get, for our members, we get to be sure that all of the healthcare providers, that their credentials are good, that the quality is good. So we talked a little bit about scope. Commissioner Goins also mentioned scope of the statute. I'm an old bill drafter, so I'm a little bit nerdy on this one, but in the definition section, we say comparable health care services includes but is not limited to. We try to get it just to say means, but the four that they actually list are the ones, similar ones that are used in Kentucky. They're occupational and physical therapy, they're imaging services such as x-rays, MRIs, mammograms, they're lab services, and they're infusion services. So those are the four that are specifically mentioned by the statute, but then it's broader than that because it says includes but not limited to. We talked about that a lot, and Representative Smith told me to hush and not talk about that anymore, so I couldn't get that to be means. Let's see. Just another concern, the folks who know what the price is are the providers. Our bill only affects the insurance companies. Our bill only, so for 700,000 Tennesseans that don't have health insurance, this isn't going to do anything for them. So 10% of our population will take a pass. So just a concern. Concerns, probably the fourth one, I prefer right to shop. We have the right to shop for professional services every day. It's different from buying a box of pencils. I don't care about the quality of a box of pencils because I know what a number 2 pencil will do. But when you're buying a professional service, just as you would with a doctor or an architect or an engineer or a landscape architect, your evaluation of that process is different. It's going to be something like maybe their qualifications, do they have any gray hair, where's the facility located? When I go to the doctor's office, to use the story example that several of us has used, Mr. Ridley, you need to go downstairs for your lab work. I go, yes, ma'am, I'm going to go downstairs for the lab work where you're going to put sharp things into my body and I'll be on my best behavior. I do think about it a little bit because I do try to be a good shopper, as we're all entitled to do under the present law, but it's right there. It's right downstairs. It's one floor below where my healthcare professional was. So I sort of have to go through the calculus. Okay, I'm here. I've taken off time for work to get my healthcare service delivered. Am I going to go because I know, I really do, that just down the street there's someone who's a little cheaper? So those are the things that you balance together, I think, in that calculus of making that decision that makes this a little bit complicated. So I prefer the shared incentives title. Is the right to shop to me is a little bit different because I think we have a right. Y'all wouldn't, the legislative members on this statute or the city council members or the county officials, y'all wouldn't have to do a single thing to give someone the right to shop. What you have to do is, I think, to change the culture that all four of us have talked about is to get them to think that way. When I went to the doctor when I was a young child, my mother never asked how much it was going to cost. She never asked. But I think today, with the price of the services, it's a cultural change. Representative Smith used the word structural change. And how do you encourage folks to make that, to get into that calculus is the hard part. Crystal Ball, your report, as Ms. Berry mentioned, your report's due in December. The statute only took effect on the 1st of January, so we're 16 days in. I've got a bucket full of materials about this, and I've got 5 minutes. I can just barely tell you my name in 5 minutes. So I look forward to working with you and your staff and would be happy to provide other materials like the other speakers. I have the other state statutes that we've looked at and the extent of their plans. As Speaker Sexton said, there are no silver bullets for this. We must be disciplined and patient as we work into something as big as $3 trillion and 18% of our gross domestic product. And also, I commend to you, this is so important because the UT study to the governor that was just released talked about health care as a factor of our economic success in Tennessee. that our smoking, our obesity, and our sedentary lifestyles lead to have an economic effect on us when other employers look at Tennessee and go, wow, look at our workforce. We like our barbecue. So we've got a lot of teachable moments there that we have. But thank you. You've been very kind to listen to me right along. I look forward to working with y'all and the other presenters as we work through this issue.
Thank you so much, Mr. Ridley. That's the presentation's questions, and the first one I have is Representative Parkinson. You're recognized.
Thank you, Mr. Chair. I knew to get on early. Mr. Chair, I want to caution Mr. Ridley on his barbecue reference.
Yes, sir.
You know, maybe
We'll take it.
It probably would have been set better if you said hot chicken, but
That's
you
a
said,
Nashville
but
thing.
you chose right, exactly. Thank you for getting my point. Thank you for your presentation. I think it's a wonderful presentation. Mr. Ridley, I think you brought up something that was, I think it's important for us to make sure that we key in on that. This wonderful legislation by Chairman Smith, it benefits people with insurance.
Yes, sir.
Right, and if I'm not mistaken, Kentucky did adopt a version of the Affordable Care Act. Am I correct in that? Maybe I should ask somebody from Kentucky. I was trying to be nice when I said it. Yes, yeah, expanding Medicaid. Right.
We did, but we're having some recent changes with
Right.
the new change of administration.
Okay, right. Thank you. You said that very nicely too. Right, right. I understand. But the individuals that were able to receive insurance through the expansion of Medicaid were able to benefit from y'all's version of the policy that.
Well, from what I was speaking to, so that's an excellent
know yours
question,
is public,
sir.
I'm sorry.
I'm just the public employees, so.
Right. So
That's
that is a question. Maybe I
It-
should put it in the form of a question.
The answer is no.
No. Okay.
Right.
Can you explain that?
Sure, there's a couple of different reasons why. One,
We
it
don't
was just,
have a
it
statute.
was just a policy decision for them to pursue this transparency for public employees. To be a little bit more wonkish on this, there's actually issues in the federal Social Security Act related to giving some sort of incentives to Medicaid enrollees that would need to be addressed at the federal level. That's far more information than you probably care to know. But the short answer is no, it doesn't impact anybody on Medicaid.
Okay. And the reason why I was and thank you, Mr. Chair. Am I still recognized?
Please.
Okay. And the reason why I was asking because I would wonder why if public employees could benefit from such a great policy, then why not the rest of the general public that needs this also? And you and if you don't mind, Mr. Josh, you had mentioned there were 5 differences or basic differences between the policy that we've created here with Chair Lady Smith. Can you tell me what those 5 are?
Sure. There's a couple different things here. So the bill that Chairwoman Smith moved forward did impact the individual and small business market in some ways. So it's a little bit broader than what we've been talking about in Kentucky. And in Kentucky, they actually moved it through one chamber and ran out of time in the other. So putting that aside, the 5 differences that I see are kind of the actual paid price. The Kentucky law focuses primarily on averages. So having the real prices disclosed for all or most services goes beyond what's in statute. That it would apply to all plans in the individual and small business market. Other states have, sometimes it's just in the small business market, others have required it across to all plans. In most other states, there's not a cap on incentives, and Nathan references this, that when you go through the legislative process, conversations and compromise happen, and this is one among many of these. I think the rationale there was, just for context, usually when you make $600, if you were to get paid $600 of cash, you'd have to report it to the IRS. And so the thought was, well, then you'd be triggering a taxable event and people would have to pay taxes on that. It was a policy decision. We have our own opinion on whether that should happen or not, but that was one main difference. And then the final one is that states like Arizona and Maine have this out-of-network provision that I referenced. So just give you a concrete example. This was a real case in Maine. Independent physical therapist was 1/3 of the cost of the other local facility physical therapists. There was some politics in the negotiations. The independent physical therapist got kicked out of the network. And so the patient who was paying 1/3 less now has to go to the in-network one that's 3 times more expensive. This change that to saying you can keep going to the independent physical therapist, pay them, and then turn around and your insurance company would give you credit like it had been an in-network experience. There may be some disagreement on whether that's a great idea or not at the table, but that was the policy.
Thank you, Mr. Chair. Thank you, Mr. Chair.
All right,
Thank you.
Representative, I'm sorry, Mayor McDonald, have you next?
Yes, thank you. Ms. Berry, could we get Mr. Archambault, is that right?
That's right, but Josh is fine too.
If we could get his comments sent to us, he seemed to have them prepared in a written form. That would be helpful. And then to our friend from Kentucky, you know, people my age, we're accustomed growing up with the saying, you get what you pay for. And so overcoming that mindset is something I think we've got to look at. How do we get people as they get older to not feel that that's automatically the answer? So I am interested in how we as Tennessee would follow the quality of care. You know, you've got a lot of data on the cost of care, and it will be very important to me to be able to see in Tennessee, if we do something like this, are we following the quality of care, and does it diminish when you only use the lesser cost issue?
Right now that we're using, when you're looking at a colonoscopy and the mammograms or going in to get an MRI or some of the other things that you can shop for, we've found since 2013 that a lot of those things, there's no difference in quality. However, we do recognize that there could be a difference in quality. If I go, you know, my mom passed away of breast cancer. So the person who did her mammogram did an excellent job of looking at that mammogram, and they found it early, but it still, you know, was too late later on. So the quality of that mammogram, yes, is important. For the most part, those kinds of procedures, you're not finding the big quality difference. What we are finding, and now we have the tools, we've not had the tools until just recently, where we have companies like Quantros, we have the 5-star program, and my mind just went blank. There are a couple of others that are out there that you can use and find the quality. I've looked at data recently, was totally surprised at a hospital that everybody thinks they're the high quality for this particular surgery. Well, my husband had a cardiac event recently. He went to the best cardiac place, but if I look at the data, that is not the place I want him to go, or me, to go get hip surgery. Because you want to go to the place that's, that does a lot of hip surgeries. And then you look at that with the cost. And so the new program that we're implementing, I think to your point, we're now getting there as an industry. But we have to start with helping people understand that it's okay and it is important to ask the questions about the cost, because that's the thing that's key, and getting members to engage. And we're at the place now, if we aren't providing an incentive or we don't look up, and it does take a partnership between our medical TPA and the vendor who's doing, a smart shopper who's doing the transparency services. Some of those TPAs don't like to give out the cost, right? But they have to. But we have to get to a place where, and we have members who come to us and say, Jenny, I wanted to shop for this, but it's not one of the listed items. How do I do that? So, you still have to go back to what are the things that will help save you money. Those are the items we're going to incentivize, but that tells me we have a culture that is moving toward, I want to know what the different costs are, whether it's incentivized or not.
Thank you.
Representative Smith, do you have a comment you'd like to make?
I do. Thank you, Mayor. One of the things about the bill as it's written and signed into law for Tennessee is, unlike one of the assertions that Mr. Ridley had made, this is an in-network bill. we do not incentivize or in code, we do not encourage out-of-network shopping. And for the very reason that you articulated, I do find that because this is working with our current state plan and in addition crossing into the commercial space, these companies do a lot of fine work to make sure that they do have an in-network experience that does leverage quality. And so because, sir, we chose to write this to be an in-network shopping experience, there is a built-in quality metric that each of the insurance plans, and that's where we gained some compromise, because originally the bill, as it was drafted before submitted, it included all shopping, and then we limited it down to in-network shopping for the very reason that you expressed, because there is a subliminal belief or an unspoken belief that the higher you pay, the more you pay, the better the quality. But in the case of the in-network shopping, you're going to see all providers listed that are in networking. Thank you, Mr. Chairman.
All right, thank you. You're recognized, Mr. Hill. I think
Representative
you wanted to
Smith
make a
and
comment.
members of the commission, I apologize if I misspoke. Part of the charm of the Tennessee statute is it is limited to in-network providers. That was our concern with the original legislation, and that was part of the compromise, because the health plans, we never, if you notice the vote on the bill is almost unanimous on the floors of both houses, and it was because the health plans got more comfortable because it was limited to only in-network providers, and I apologize if I misspoke earlier. So, but no, I'm painful, very clear on that. That was an important, as Josh and Representative Smith know, and all of y'all know, that was part of the give and take of the legislative process.
All right. Representative Crawford, you're recognized.
Thank you, Mr. Chairman. If, is it Josh? If you could make sure to get that to the chairman, the information, so we can digest that. You went awful fast a while ago. I was going to try to get you to slow down so I could understand it. But I just want to make sure I understand this in my head. But when we were talking about quality, as the mayor brought up there, I would assume it wouldn't matter whether the lower cost vendor or physician, whoever, they still all have to meet all the regulations of the medical boards and stuff, right? So they should be meeting all standards that we've required here in Tennessee. I just want to make sure of that.
Sure.
Okay.
Other questions or comments? Yes, ma'am. I'm sorry. Go ahead, Mary.
This question is for Commissioner Goins. So do you currently have a database for shoppers that would need to access reviews of various medical facilities or doctors?
What Smart Shopper is, that's a very good question. What Smart Shopper is using is a database that they're pulling in from Medicare, the 5 stars programs, and then a company called Quantros. But then there are also, I remembered the name of another one, Leapfrog, has been out for a very long time. So there are several companies out there that are now providing quality measures for various services. Not everything yet, but a lot of the higher cost type items, you can get that data, especially hospital type procedures.
Okay.
And Josh may have more information on that than I do.
Yeah, I would just say one of the things that's interesting about these, and they have an app, they have a website, or you can call in. And I think the goal of the demonstrations we've seen from a number of these providers is their goal, vendors, is their goal is consumer friendly. And so they want you within 30 seconds to a minute to be able to know what your low cost, high quality options are. And so they're really designing their products so anybody can use it. You know, anybody can pick up the phone and call and say, I need this colonoscopy, give me the 3 ones in my area that you would recommend. So that's the goal, and they really are very creative and changing them all the time. It's very encouraging. So.
All right.
Thank you, Chairman.
Mayor Anderson, I think I saw you earlier.
Thank you, Mr. Chairman. To Ms. Goins, in Kentucky, are you having the same issues facing your state with the closure of small rural hospitals?
No, sir, we're not. I did read about that, and I actually was part of a presentation at the National Alliance on Health in November, and so I learned a little bit more about the issues that you're having. with hospital closures. I will tell you that we call it the Golden Triangle, and that is the area between Louisville, Lexington, Cincinnati, and back. So it does make kind of a triangle. And then we have some outliers in Bowling Green, for example, because it's so close to Nashville here that we actually have people who come into Tennessee for service or for providers. So we do have rural issues in the extremes, especially in eastern Kentucky, and we try to pay attention to that. And this is a little off subject, but we've been using telehealth to help us in those areas as a health plan. We try to be very innovative, but we don't have that same issue that you're having in Tennessee.
And as a follow-up, do you have CONs in Kentucky?
Help me with that one.
Certificate
CON?
of Needs.
Yes, we do.
Thank you.
All right, other questions? Did I overlook anyone? Ms. Gaither, did you get all your questions? Very good question. Anyone else? All right, ladies and gentlemen, thank you. Terribly informative, interesting. Thank you. All right, ladies and gentlemen, next on our agenda, we are going to approve the annual report on Tennessee's public infrastructure needs. Oh, is it? I'm sorry, I'm on the wrong page and making my notes. Senate Joint Resolution on the illegal tire dumps, final report for, am I skipping one? Okay, I'm sorry, tab 4. Local government procurement and the acceptance of online bids and other offers. Dr. Lippert.
So you'll recall this is a report, Nathan Shaver presented the draft report on this at the last commission meeting, and since he has left us for other venues, I'm batting cleanup for him today. So I'll be presenting the final report for your approval. We have not made any significant changes to this report since it was presented to you by Nathan at the last meeting. As you recall, the purpose of the study, currently e-procurement or online bidding services is an option available to local governments in the state of Tennessee. And the bill we were asked to study, House Bill 635, would have made this a requirement that local governments accept online bids and other offers through a secure electronic interactive system. Now, there would have been some exceptions, some exemptions from this requirement, and there would be counties with populations less than 18,000, cities with populations less than 9,000, or any local governments that did not have computers or high-speed internet access. As you recall, after meeting with the various stakeholders on this subject, the report found that while recognizing the potential benefits of receiving online bids and other offers, the Commission does not recommend making e-procurement mandatory for Tennessee's local governments. It did recommend that if lawmakers want the state to have an e-procurement system that local governments could use to receive online bids and other offers like Maryland and Virginia have, they should consider upgrading the state's current Edison system. Of course, so reports found at tab 4. I'd be happy to answer any questions you have about it, but at this time I would ask for your approval of the report.
Mayor McDonald.
I'd like to move it.
Second. All right, we have a motion and a second to approve the report, recommending that we do not require, and just to make sure, because I'm dead set against it, I want to make sure we do that. You mayors and county mayors can decide what you want to do. I don't need to tell you what to do. All right, we have a motion and a second. We ready to vote? Any discussion? All those in favor say aye. Aye. Any opposed? Passes. All right, thank you. Now we're down to tab 5, Joint Senate Resolution, illegal tire dumps. We're ready for the final report on that. Bob, you there he is. Thank you.
Thank you, Mr. Chairman. Good afternoon, everyone. My name is Bob Morio. I'm pleased to present for your approval the final draft of our report on the effects of illegal tire dumping in Tennessee, located behind tab 5 of your docket books. The report was prepared in response to Senate Joint Resolution 344, introduced by Senator Dickerson in March of 2019. Since the Commission's December meeting, the language of the 3 recommendations presented in the draft report was revised somewhat for clarity, but overall the intent has not been changed. Some supporting information has been added throughout the report to better describe some of the ways funding and responsibility for tire disposal is shifted over time from the state to county governments, and the effects these changes have had on counties' options for handling waste tires. The first report says that the taxing used tire sales the same as new tire sales and regulating the transport of waste tires would improve local government's ability to track all sources of scrap tires in their communities and help reduce illegal dumping. You'll see on page 4 that the final report added one detail to the draft's second recommendation, which is that Tennessee should require permits for waste tire haulers. The revision adds that registered tire retailers may either document and transport their own waste tires for proper disposal or would use only those permitted haulers. And additional information also explains that having such permit requirements would give law enforcement officers opportunities to stop and inspect vehicles transporting tires, hopefully to prevent illegal dumping. On page 5, the report's third recommendation, to give counties more flexibility to spend their tire pre-disposal fee money has been expanded upon to better address that there are really two separate concerns. The final report recommends giving counties clear authority to use their revenue to fund public education, inspections, enforcement efforts directly related to preventing tire dumping. And lastly, although the preferred policy is to find beneficial end uses for waste tires, the report suggests counties should also be allowed to use pre-disposal fee revenue to shred and dispose of some tires in landfills when circumstances are that finding a beneficial end use has been documented to be extremely cost prohibitive. Thank all of you for your feedback and discussion, and the folks at TDAC, Department of Revenue, and everyone that helped us out along the way. I'll take any questions if there are any concerns, or ask for your approval for the report.
All right, we have the report. Bob, thank you. You've met with me several times on this. This is a real problem. We've got a building full up in the center and Chairman Crawford's area. I guess we've got tires everywhere. I know that Mayor Greer has a real problem with it. Are there any questions or concerns? I know in trying to get a bill drafted, we ran into this as a pretty complex report and pretty difficult. So if there are any questions, let's make sure we get them hammered out now. Sure. Senator Yeager?
The county government representatives are here. I'd like to hear from the county governments. Is it allowed to ask? Maybe
I don't mind.
Mr. Connor just walked in. I'm sure his organization has a position on it. Could we ask?
Sure, we can.
Right.
Do you mind, Dave, Mr. Connor, if your
He's
group
barely
has
got in his
taken
seat. Mr. Chairman, I'd like to hear from what the counties have to say about
Sure,
this.
absolutely.
There we go. David Connor with the Tennessee County Services Association. I was out in the hallway and just missed the very closing part of that. So if there's something specific, is there a specific question or just in general about the issue of waste tires? It is a severe problem across many parts of the state. We definitely know that. The challenges of recycling tires are very difficult waste to deal with, which is part of what leads to illegal dumping, but also the cost to the counties. We have a very limited number of people who provide the service of recycling the tires as well, and those costs continue to go up. There's only really 1 or 2 operators in the state that are working on tire recycling, and the cost that they charge to the counties for recycling the tires continues to go up and up and up. So it's definitely been a challenge to them, and the money they get on the fee that's paid for the tires for the purchasing doesn't usually cover the cost of what it takes to actually handle those wastes. So is that?
Yes, sir. Yes, Senator. Thank you.
By assessing this state fee on used tires, will that help alleviate this problem for counties?
I do think that will be a tremendous assistance to counties, because that is a section of the tire environment that's out there that tends to kind of slip through the cracks. So I think additional fees in that area, there's some likelihood that those kind of used tires may be the source of where some of the dumping is coming from. So anything that can help to address those problems would be a big assistance.
Thank you, Mr. Chairman.
No, thank you. Any other, Mayor Greer?
Thank you, Mr. Chairman. In discussing with some of the solid waste directors across the state, with regard to this program. It comes back to the point in time, we still think that there needs to be some solid permitting processes for the haulers, because our local law enforcement has no ability to stop these haulers to see if they are financially responsible for the tires that they're hauling. Our sheriff's department has on occasion seen tires going down the road in a pickup truck, and they don't have any legal way to really stop them and say, show me your manifest, where is this tire going, so we can follow it through to be sure that they're properly disposed of. So that's just one of the thoughts from the solid waste directors. Also, the amount of dollars coming into the to TDEC in this program, I don't believe we have enough enforcement people across the state from the TDEC's standpoint, and over the last 3 years, they've taken in better than $4 million, and I would like to see how that money's being spent.
Okay,
Thank you, Mr. Chairman.
Thank you, Mayor. Dr. Lippert has some responses to that and some things that are covered in the report that.
And I just
may
wanted
not
to, thank you, Chairman. I just want to make sure, Mayor Greer, that in light of your comments, do you think the language in the recommendation on page 4 is a step in the right direction on addressing that, where we say the state should require commercial waste tire haulers to obtain a permit from TDEC and provide proof of financial assurance in the form of a surety bond, while requiring registered tire retailers to use only permitted haulers or document and transport their own waste tires for proper collection?
Yes, I think that's a step in the right direction. I believe that there just needs to be a process that the local governments can follow, and I'm very much in favor of what you have down here. Thank you.
All right. Other questions or concerns? Yes, sir. Buddy?
Thank you, Mr. Chair. With the permitting process, I don't want it to be to the point, and it's my opinion, that we hurt the mom and pop shops. We've got several around Loudoun County that they're not chains, and they follow the rules. But when it comes to the licensing, put enough teeth in the penalty to where if you're not, because Loudoun County, of course, we had a huge one. He was using a U-Haul truck, and so, but we were able to catch him anyway. But put some teeth in that penalty when it comes to hauling tires without it, because we could have used that as well as a deterrent. But I don't want it to be such a fee and a requirement that would hurt the small businesses. Thank you.
Sure. Yep. Other questions or comments? In meeting with Bob and promising Mayor Greer that I'd get some bill moving on this, we've really examined a lot of this. We've talked to a lot of small businesses, much like Mayor Bradshaw just spoke about, and this can be a great burden on the small business. And so we're really trying to find a way to accomplish this without harming them. You get down to, I bought a 1946 one-ton Chevrolet, had 6 bad tires on it. Do I have to have a permit to carry those to the recycling center? They take up most of the area in my truck. And so Bob and I have discussed that at great length and with the attorney that we've talked to. So this is easy to think about and really hard to draw. So Mayor Greer, trust me, you're going to get blamed for a lot of this, because I'm going to call you a lot on this and blame a lot of it on you when it comes to the floor. But these are all issues. I really like the report. It contains a lot of different areas. You try to turn that into everyday life without punishing some of our small businesses. It's going to be very difficult. So I think we're going to have to be very careful about that. And it may take a 1 or 2 year effort to get this done. But I think everyone can agree very quickly that the adding the tax to the used tire, which our studies show that's primarily where the problem comes from, makes a lot of sense. So
Make a motion to accept.
okay, there's been a motion made to accept
Second.
and a second. Are we ready to vote? Any other discussions? All in favor, say aye. Aye. All opposed? All right, passes unanimously. Bob, thank you, and thank you for putting up with me calling you so many times. So we need to, I'll drive it to Cleveland one day. All right. We're now down to tab 6, Public Chapter 827, Global Positioning Systems Monitoring, Final report for approval.
I'm here.
Yeah, I see you.
Oh.
I thought we had someone here that was very concerned about today and wanted to make a presentation. I told them it was a little too late for presentations, but that I would hear from them, and they're not here. So I guess if they couldn't have an official part, they didn't want any part at all. So, all right, Jennifer, would you go ahead with that, please?
Thank you, Mr. Chairman. Hello again. I'm now presenting the final report addressing GPS monitoring as a condition of release for domestic violence offenses for your approval. And the report's behind tab 6. Public Chapter 827, Acts of 2018, directs the Commission to conduct a study of the effects and implementation of Global Positioning System, or GPS, monitoring as a condition of release for defendants accused of stalking, sexual assault, domestic abuse, and violations of orders of protection. Since the December meeting, we have made a couple of updates to the report to address concerns that members expressed during the panel discussion about GPS data. We added information about data ownership and use and open records considerations. This new language is shaded gray in the report on page 29. We also updated the results from the Memphis and Shelby County GPS monitoring pilot program evaluation on page 7, and added Appendix H with all of the recommendations and conclusions from the pilot program evaluation. The report's recommendations remain unchanged since the last meeting, and I'll briefly repeat those again now. To help maximize GPS monitoring's effectiveness for increasing the safety of domestic violence victims during the pretrial period, local jurisdictions should consider adopting it as but one component of a larger coordinated community response, including strong interagency partnerships, cooperation and commitment from stakeholders, education and training, and victim support services such as family safety centers, domestic violence high-risk teams, and lethality assessments. Local governments that choose to implement GPS monitoring programs should work with partner agencies to clarify roles and expectations and develop and commit to procedures and policies. Regardless of whether local governments choose to implement GPS monitoring programs, law enforcement and victim advocate agencies should be encouraged to adopt validated lethality assessments because they are an effective tool for identifying victims most at risk of serious harm or death, and they help prioritize victims' access to safety planning and other services. Given the importance of operating a pretrial GPS program within a larger coordinated community response, if the General Assembly appropriates additional funds, specifically for real-time GPS monitoring of domestic violence defendants, it should require that local governments drawing money from the Electronic Monitoring Indigency Fund, at a minimum, adopt a validated lethality assessment tool to help identify which domestic violence victims are in greatest danger and immediately connect those victims with safety planning and other services to improve their safety. Local governments adopting pretrial GPS monitoring programs may also choose to prioritize high-risk cases and certain types of offenses, including intimate partner violence, strangulation, stalking, threats involving firearms, or violations of protection orders. And just to remind you, the final report is due to the General Assembly February 1st. So thank you for all of your input and support as we worked on this study, and I now ask for approval of the report.
Questions? Senator?
Thank you, Mr. Chairman. Just curious, Mr. Chairman, the individual or group that approached you, did they give you any indication of what their concern was?
It wasn't a group. It was a legislator who had not been, didn't realize we were this far along.
Great.
So,
thank you.
Anyway. Other questions? Or Mayor Anderson?
On page 32, just refresh my memory, there are 18 counties listed there that are committed to the EMIF program. What about the other counties that did not commit to that? How is that going to work?
Next year, they'll be able to commit to it. There was a timeline that was given,
Right.
and I don't remember the exact timeline, but they'll be able to join the program, choose to participate for the next fiscal year.
So I think, Mr. Chairman, if I could follow up on that.
Certainly.
Because she's struggling with that a little, and it's, even though I remember coming to the seminar on this that we as mayors had in Sevierville, I know there's a few of us here, we did put some money in, but there are counties that aren't listed here that I wonder how they're going to be affected. So public education on this to all of our counties is going to be important if they're going to want to participate in that.
Representative Hardaway and I have been discussing this for some time. Our thought is that the GPS monitoring device for a period of 30 days is in lieu of bond, so you don't get to the indigency question. You follow me? Indigency doesn't follow the bondsman. Everybody's got enough money for the bondsman. You follow me? So when you see the bill, it may not make a lot of sense to you, but we can't tax our cities and counties with this debt. It's just, that's not what we came up here to do. So as a former judge, it always amazed me people would post a $10,000 bond and file an application for indigency. I would simply say, well, I'll just put you back in jail and get your money back and hire a lawyer with it. Instantly, they had money. I'm sorry to the Supreme Court who has advised us that's not legal, but I'm not there anymore. So that's more of our view. If we pass a statute that says there is no bond for this offense, in lieu of bond, you must pay for this device for 30 days. That cooling off period, it usually takes about 10 days, not 30 days from my experience. Secondly, I've met with judges that I know and have called a lot of them and had a meeting with 7, at least in my area, people charged with these assaults are upper middle class very frequently, where money is not an issue. So I don't know where we're going to get. Jennifer, please don't, if we do something apart from your report. This report is beautiful. I love what they've done in Shelby County, but they've got it so complicated, so expensive, it's never going to work in my county. And so we're trying to find a way around it. I love all this. If we have plenty of money, this report's incredible. But I don't see, we need some way to show that victim we're going to protect them. We need some way to show that defendant that we're watching you, and that's going to cut down this behavior, in my opinion. I can't tell you how many times I sat there with my thumb up my nose, who's telling the truth. I just want something that's going to tell me who's telling the truth, and then the judges can take care of it. I'm very concerned because when I was there, domestic assault was at the top of our list of importance. Ladies and gentlemen, in the little tour I made a couple of months ago, it had fallen in status of importance. And that staggered me because it is far more prevalent, far more damaging. It is incredible the number of cases I had. And all of the studies show if you grow up with it, you do it. I mean, I think there's complete, if you're taught that's a normal, then that's going to happen. So anyway, the bill that we're drawing may not reflect much on this, but if I can't afford a Cadillac, maybe I can buy a used Chevrolet. So, no, just in case you all see that in the paper or something, you'll know that if you have questions or objections to it, now would be a great time to tell me. But we've got to do something. So, questions, comments? Oh, Senator Robinson.
Yes, I'm sorry, I may have missed this. Thank you, Mr. Chairman.
Sure.
Is there a reason why Shelby County isn't committed to the NIF?
I'm sorry, I couldn't hear your question. Your mic may not be on.
Is there a reason why Shelby County is not listed as committed to the EMIF participation?
I don't know why they have not committed to participation in the program, but yeah, they're not, according to this information from the Treasury Department, they're not committed to participating for the next fiscal year.
I mean, was there any feedback in regards to why they were not, there was none provided at all?
No.
Okay, thank you.
Now, Senator, they were here. I'm not sure if you got to make that meeting. They were here. The entire thing revolved around them. They have a wonderful program. A professor, I think from Memphis State, wasn't she here? She called me the other day willing to come up and help. So they've been basically the subject of the study. But I don't know. It may be because they have this pilot project that's being financed outside that they don't need to be in it. I think that's the reason, but I'm guesstimating.
As a member of the Crime Commission
okay.
in Shelby County, I can assure you that that's what it is, is we're doing this joint program with University of Memphis, and our ability to share information as it comes through with each other. And so I think it's just a matter of timing on, we got started with something and it got funded, so it's happening.
One question. I was under the impression that those funds had been expended already.
You were what, under the impression? Well, that may be possible, but at the time that these were reported in October 2019, I don't know that that was the case at the time of this report.
I understand. Thank you.
Yeah.
All right. Jennifer?
I was just going to say, the grant program has completed. I think that's what you were referring to, but they are continuing a program and they're funding it through local government. So the program is continuing, but the grant program has completed.
Other questions or comments? Something just crossed my mind for those of you that think that the person may not have money, can't make a bond to buy one of these. We already have rules set up. If you can't post a bond, you have to be taken before a judge expeditiously. So we're not changing anything from other cases. So I'm sure I've oversimplified this. I'm sure it's stupid, and I'm sure it won't work, but I'm going to try it anyway. All right? It's never stopped me before. All right? Are we ready to vote? Any other questions or comments?
Move it, please.
All right, we have a motion. Do we have a second? We have a second. We have a second. I knew he wanted to. He was just thinking about how to do it. So we have a motion and a second. All in favor of the report, say aye. Aye. All opposed? All right, passes unanimously. Jennifer, this has been an enormous undertaking. I'm not sure. I know the day I walked in, it was going to be so simple, and I left with just bumping into the walls with all the issues you had raised. And so this has just been yet another example of the great work you all do. So thank you very much.
Thank you very much.
Well, we got through a little quicker than I had anticipated. Yeah, we passed the last one that I thought was going to take so much time. Any other questions or comments? I know you're dying to stay here longer. You can stay and loiter if you'd like. Loitering. Loitering. Anything else? Anyone have any questions or comments? All right. Do I hear a motion that we adjourn till in the morning at 8:30? All right. We're adjourned. Be back at 8:30 in the morning. And you may leave your books here. You don't have to carry them home and bring them back.